Good morning. It's my real pleasure to be here today. I also want to congratulate the organizing committee for putting together such an outstanding program, and I feel honored to be here and be part of the program. I also want to thank you for getting up so early today and coming and participating in the sessions today. I think you'll get a lot out of them. A couple of months ago, I was speaking with an anesthesiologist in Southern California who told me that suddenly, for no reason, he thought the hospital was doing a lot of investigation and auditing of their utilization in the labor and delivery operating room. And the idea was that the administrator had been working in the main hospital and was wondering why the utilization of the OR and the L&D was so low. And when I heard that, I said, well, obviously they don't understand that labor and delivery suites are different than general operating room suites and certainly outpatient surgery centers. But the real question was, how do you tackle something like that? And I know a lot of you are facing similar challenges. The hospitals and L&D suites are under enormous pressure to get as many patients through the system as possible because of the huge overhead cost of the hospital and the facility. And I'm going to go to the next slide with this little guy here. In terms of disclosures, over the years I've consulted with lots of different companies, and most recently that was Merck. And in terms of learning points, when you go home and you think about what I've said today, when you get that OR utilization metric for your labor and delivery suite, the first thing you need to ask is, does it include turnover times or not? You can imagine that if you include turnover times and how you figure things out, the numbers are going to look quite differently. And this is really critical because if you benchmark your facility with another facility, one includes turnover times and the other one doesn't, you're going to get really very different comparison, really apples and oranges. So you need to understand the data that you're getting from your administrator. You need to ask questions. You need to figure out how it was computed. You really need to dig down. And then the other thing that I see in the hospital is that people use different definitions. So you go to a meeting to discuss the utilization of the labor and delivery operating room. Some people believe utilization is one thing, other people believe it's something else. Unless everybody agrees on the same definition, you're not going to get a lot done. And all of you who practice obstetric anesthesia obviously appreciate this, but people that don't may not. Labor and delivery ORs are different in that capacity is needed for emergent cesareans. And different hospitals and labor and delivery suites manage this differently. And besides utilization, there's lots of other measurements that you can make to figure out how well functioning your labor and delivery suite really is. And we're going to talk a little bit about those in the main operating room. Things like how often your cases start on time and how long your turnover times are good things to track. And I think this is probably the main take-home point I'm going to make, because people really want a silver bullet, a magic answer. They say, our utilization is low, what should we do to improve it? As if there was one answer that would apply to every hospital. And unfortunately, each place is so different with its own unique characteristics that what might work at one place is not going to work somewhere else. So there is no magic bullet, there is no single solution. You really need to do a local assessment and then implement what you think is going to work for your facility. So this is a report that you might get as the chief of obstetric anesthesia, and it has the block utilization for different locations in the hospital. And I just highlighted a couple. The OB unit on Monday has a utilization of 48%, on Tuesday 50%, Wednesday 37%, Thursday's a little higher, and then Friday 76%. And so at first glance that might seem interesting in that it's different depending on the day. Some people might focus that it's maybe lower than some of the other places in the hospital. What do you do with those kind of data? Well, the traditional thinking is that you can't really have 100% utilization because it'd be impossible to perfectly match the workload and the staff. 90% is pretty good. And you really have to work hard, the clinicians and the managers and the nursing staff and everyone, to really achieve this. 80% is probably what a lot of hospitals that are performing pretty well are doing. And then 70% is acceptable, and then anything less than 50% really is low. Now you see a lot of outpatient surgery centers that do sports medicine type surgeries that have a utilization that's 50%, and they seem to be doing fine, and that's because they promise surgeons quick access to the operating room. So if I'm seeing a patient who has a knee pain and want to schedule an arthroscopy, I need to be able to do that next week. In order to be able to schedule a case on such short notice, you need to have ORs that are open and staffed for cases. And then obviously anything less than 30% is really quite poor. So what is utilization? Basically, it's the time used and divided by the time available. Now, the time available is obviously how much time during the day there are staff to do the case. And then the time used is going to include how long the patient was in the room and any turnover time. So let's look at what that might look like. I think most hospitals in the United States and around the world, in fact, assign OR time to either a surgeon group, or a department based on historical utilization. And the problem is that this approach has limitations if the goal is to minimize the throughput of cases and OR efficiency. We should be more sophisticated in assigning block time to groups than simply relying on utilization. So let's get to an example of why this can get confusing to people that don't think about this every day. Let's say you're in the labor and delivery room 1. You come into work in the morning and there are 4 elective cesareans. It turns out that at your hospital they only take 90 minutes, and each case is followed by a 30-minute turnover. I hope that's representative of some of the locations of all of you who practice in OB. So what is the OR utilization here? We know that there are staff to do the case between 7 and 3, so that's 8 hours. We know that the patient's in the room for 6 hours, and we know that there are turnover times that equal 1.5 hours. Well, you could calculate what's known as the raw utilization, which is the occupancy, not including turnover times, divided by the staff OR time. So that means that in this labor and delivery room with 4 cesareans, each lasting 90 minutes, not including turnover time, the utilization that day was 75%. Now, you could argue that really what we want to know is, since you're not going to have a patient in the room the whole day for a cesarean, typically, you would need to really include the turnover time, because otherwise you'd never be able to get anywhere close to 100%. So some hospitals use adjusted OR utilization, where you include kind of a reasonable amount of turnover time in the calculation. So in this case, the utilization would be 6 hours if the patient's in the room, 1.5 hours of turnover, which is a utilization of 94%. I think this number, in a lot of ways, is probably more reasonable from a management point of view, because most people would say if you're able to get through 4 cesareans by 3 o'clock, that's been a pretty well utilized room. 94% seems like a good number. Now, if another hospital uses raw utilization and you compare the 2 hospitals, you're going to get 2 different, very, very different perspectives on how well the room was used that day. It gets more complicated as you think about it more. Let's say you work at a L&D suite that has got 2 operating rooms. They're both scheduled from 7 to 3. And you go to work on Monday, and when you leave, you realize that the first room had a bunch of cases and turnovers, and it got done at 2, meaning there were staff assigned to be in that room till 3, but the room finished early. And then in the other room, there were staff that were scheduled to be there till 3, and that room finished an hour late. So the question then becomes, what is the OR utilization in OR2? Well, it could be 100% because there were patients in the room or turnovers that were deemed reasonable during the entire day. Or other hospitals would compute with the data system that the utilization was 113%. And so unless you know how rooms that run late are measured in terms of utilization, it's going to be hard to figure out, because if you take the average of these 2 rooms, It depends whether you use the 100% for room 2 or 113%. How about this scenario? You've got a room that's scheduled with staff from 7 to 3 and it runs till 2:30. The other room goes a couple hours late. And the question is, if you're running the labor and delivery suite and someone says, has the OR efficiency been greater or smaller on day 1 or day 2? In other words, well, let's try to think about that some more. Underutilized time is the amount of time that the OR finishes early. So if you're running the room from 7 to 3 and the last case finishes at 1, you've had 2 hours of underutilized time. That means that you have staff, both anesthesiologists and nursing staff, to work in the operating room, but there have been no cases in there. So if the room finishes early at 1, you've had 2 hours of underutilized time. In contrast, overutilized time means the amount of hours that the room runs late. So you've got staff from 7 to 3, and the room runs till 6. Now you've got 3 hours of overutilized time. And as all of you know, typically the cost of overutilized time is higher than the cost of underutilized time. And that's because if the room runs late, you have to pay the staff overtime. And perhaps even more important than that is that if your room is always scheduled to end at 3, and every day you have to ask people to stay late, morale will go down and people won't want to work there, and then you're going to have to recruit other people to replace the people that left. So typically, when you're trying to figure things out, I suggest using a number like twice, that a room that runs an hour late costs the system about twice as much as a room that runs finishes an hour early. And that can vary depending on the facility. So in general, what we try to teach is that the inefficiency of the use of overtime is the number of hours of underutilized time, how many hours in the labor and delivery suite that the OR finished early, plus the number of hours that the room finished late multiplied by 2. So if the operating room was perfectly run, it would always finish at 3 and never would run late, never would run early, and then there'd be no inefficiency of OR time because the room always finished at 3. Obviously that doesn't happen. So the goal of the OR manager is to try to minimize the rooms that finish early and minimize the rooms that run late, understanding that a room that runs late is more expensive to the system than a room that finishes early. So for normal hospital operating rooms, this is non-labor and delivery suites, I think that we can say that nothing is more important in OR management than to first allocate the right amount of OR time to each service on each day of the week, so that rarely do services fill their allocated OR time and have another case to schedule. And the best way to figure out how much operating room time to allocate to a surgeon or a department is to look at their prior use of that operating room and assign an amount of OR time that will minimize the amount of days the room is done early and minimize the number of days the room's going to run late, understanding that running late is more expensive than finishing early. So one way to think about this is, let's say you've been assigned to work in the main hospital now, and that you're not in labor and delivery. And on that particular day, it turns out that there are 2 cases, and each is going to last a couple hours. And there's an OR team, including an anesthesiologist, to work an 8-hour day from 7 to 3. Well, you could argue that the matching of the workload to staffing on that day has been so poor that little can be done on the day of surgery, such as reducing turnover time or starting on time, to really increase the efficiency of use of nurses and anesthesiologists. Now, many hospitals have a big, long wait list, and those cases might be put in here. Some hospitals pay their staff hourly, so if the room gets done early, this isn't as big a negative. But generally, the most important thing an OR manager can do is to make sure that the amount of OR time the surgical team has gotten is as close to optimal and correct as possible. And that requires a lot of advanced planning. And unless that advanced planning is done properly, on the day of surgery, kind of running around trying to get the IVs in started faster or reducing turnover really aren't going to have as much of an impact on the OR efficiency. So in terms of labor and delivery, the staffing OB units is unique because all parturients seeking admission must receive care. This is different than an outpatient surgery center. If there's a problem with staffing or there's not an operating room, the outpatient can come back some other day. And in OB, we really need to take care of all the patients. So that means that the inflow of patients and its characteristics are quite different than normal hospital. And the other thing that's different about the OB suite is that the arrival of the parturients, unless they're elective cesareans, is really quite random. They can come in at any time during the day or night. And as a result, your staffing has to reflect that. We're not going to expect patients to arrive to the main hospital operating room unless it's an emergency on a Saturday very late in the day, whereas in OB, you could have lots of patients then. And so that means that OB units in general often have to have empty but staffed beds in OR time. And sort of figuring out what the sweet spot is where you have enough unused capacity to take care of all the patients and not having over capacity where you have too many staff, that's the challenge for all of us. Now, obviously, some OB admissions are known ahead of time, such as patients scheduled for induction of labor or scheduled for elective cesarean, and each labor and delivery suite is going to have a different profile for these kinds of cases. And sort of the corollary to that is that if you have a high OR utilization, this correlates poorly with waiting times for quick access to the operating room. So in other words, if the obstetrician wants to add a cesarean for tomorrow because they see the patient today, and the L&D ORs are perfectly 100% utilized, then the obstetrician won't be able to admit that patient. So we have to have a lower utilization than we would in a typical hospital to have give obstetricians access to the operating room. Although facilities may believe a high utilization can be achieved without sacrificing access to OR time on short notice, these two aspects are not separable. And I hear this all the time in the hospital. We want to have a utilization that's super high and at the same time guarantee access to labor and delivery on short notice within a couple days. You just can't have that. Mathematically, you can't have 95% utilization and have enough unused capacity the next day to have patients that need to be admitted. And this is a difficult thing for hospitals to, and the people that you speak to who help run the hospital to accept. The greater the OR utilization, the less the convenience, able to book cases when desirous for surgeons and patients. There's a trade-off. And this is one reason outpatient surgery centers for labor and delivery suites typically have lower utilization than inpatient ORs. Now, what about OR efficiency? As we think about OR utilization and what it should be in the operating room and in the labor and delivery, everyone has sort of a different definition of OR efficiency. I think if you were asked patients, many patients would think, okay, my case was scheduled for 2 in the afternoon. It started around 2. That means that the operating room is running pretty efficiently. On the other hand, the obstetrician may think that an efficient labor and delivery suite is one that will accept their patient quickly on short notice and take great care of the patient. A hospital manager might focus on high utilization. They really want to minimize overtime costs, and they want to minimize complaints from the physicians and nurses and patients. And this was a study that was published a few years ago, but I think about it a lot. As we try to manage utilization in the labor and delivery suite, there are 3 general stakeholders. There's the physicians, there's the nursing, and then there's the administrators. And if you ask each of these groups who has the greatest power to change and make improvements in the hospital, including the operating room, each group thinks it's the other group. So if you ask doctors, who do you think has the greatest power to make change and improve the system, the doctors typically say the hospital administrator. And if you ask nursing, they say it's the doctors that have the most power to get things done. And then if you ask the administrators, they think it's all the doctors that have all the power. So you go to a meeting, you're trying to manage OR utilization, and you have an administrator, a nurse, and a doctor, and they all think that one of the other people in the room has the authority and the power to manage the utilization. And I think this makes it tricky to figure out what to do. And we heard earlier about how important communication is, and this also applies when you're managing utilization. And there are different systems for scoring how well your operating rooms are run. One is excess staffing costs. So how much money are you spending to pay people to stay after hours? How often are your cases starting on time? What's the cancellation rate? How often are you in the operating room waiting to admit the patient to the recovery room, either in L&D or in the main hospital, and you can't because the PACU is full? A perfectly functioning operating room suite won't ever have this, but many of us work in hospitals where this occurs every week. Turnover times is something that's often measured. Certainly an operating room suite that has lower turnover times is going to be more efficient than one that has higher turnover times. And as you go around the country and you measure these things, there's different results depending on the kind of facility that you talk to. So for instance, for turnover times, if you work at a hospital that has average turnover time of less than 25 minutes, that's pretty good. If you work at a facility that has turnover times that are averaging more than 40 minutes, that's not so good. There are some hospitals that have a lot of turnovers that are really long, like more than an hour. If you have more than 10% or less than 10% of your turnovers are an hour or less, that's pretty good. If more than a quarter of your turnover times are more than an hour, that's not so good. And the cancellation rate for many hospitals is less than 5%, which is good. If it's more than 10%, that's not so good. So I think this is a way to, once you get your data and you understand your data, you can kind of understand where you are in the big scheme of things. And then this is another way to think about the issue about OR utilization. If you take all of the minutes that the operating room is in use, and you divide it into different types of categories. So for instance, in this particular operating room at a particular hospital, the red is the amount of time that surgery was being done outside block after hours. And then the blue is the amount of time where there were people available to do cases, but there weren't any cases done. And then green is how often the case went late. So this is almost like a fingerprint that you can use that will identify any particular hospital. And based on this kind of analysis, you can figure out where you should be tackling if the goal is to really improve OR efficiency. And again, every hospital has a different fingerprint. These are two hospitals where we looked at how OR time was being used, and the relative proportions of different times was different. And you can generally say that hospital A has many days when the ORs run late. And I know that applies to lots of the hospitals that you work at, which may be quite busy, and the day seems to be running into the early evening. Whereas hospital B had less of that of an issue, but they had a real issue with scheduling cases properly. So one way to think about these two hospitals is that the first one really needs to figure out how to lengthen the staff scheduled workday so that less overtime is being paid. Whereas the second hospital, if the goal is to improve OR efficiency, should really focus on methods to improve the accuracy of this case scheduling. Because it's not so much that they're running late, it's that each particular case isn't being scheduled correctly. So to finish up, some of the learning points that we've sort of gone over. When you get your OR utilization metric, find out, does it include turnover time or not? Please work with your manager to figure out how the data was collected and what the definitions are. And please educate all your colleagues and your hospital administrators that the L&D suite is different than the operating room, and that capacity is needed for emergent cesareans. And then you can make other measurements besides ore utilization to determine how well the ore and delivery suite is functioning. And these data become dialogue for change. And this is one of the more frustrating parts, is that you go to a meeting and you discuss something, and you could have all the best data in the world, but if people don't believe the data, that doesn't mean that there's going to be change that's automatically going to be done. It's going to be create some dialogue. And finally, there's no magic bullet. There's no silver bullet that will fix everyone's problem in the same way. And thank you very much.